Yebo. Thank you. Welcome everyone to our today's session. We are looking forward to another moment to discuss and explore some concepts in palliative care. In our last session, we were looking at ethics, and then we were looking at how to handle some ethical dilemmas. So yeah, that's what we were looking at, especially when patients are at their end of life. So that's what we were looking closer to. So we are hoping we will be able to do something even today. There's something that is disturbing me here. Let me do this so we can go well. So today we will be looking at ACPs. Though we have a challenge in our country when it comes to ACPs, but this is what we are going to cover. We touched base few things that can be done for advanced care planning in our last session, but today we will look a little bit closer on just the basics of ACPs. So we'll start with Zinhle. There is a case from RFM that we would like to go through together so we can learn from it and help one another on how best our RFM team can handle this case. How are you, Zinhle? Mhm.
I'm good, Miss Master. How are you?
Yeah, I'm doing well,
Yeah,
but your voice is too low. I don't know, maybe it's my gadget. But if you can hear me, that's okay. Uh, I
I
will,
can hear you.
okay. So are you going to share the screen or am I share it for you?
Please share it for me.
Okay. I hope all of us can hear uh, our presenter. So I will be doing something very fast. Okay. Can I share the case so you can go ahead and present your case to the team so they can have their input on how best you can manage such a case? I hope that can add value in your work and assist you on how best you can attend to it, while also the team can also learn from how you are handling such a case as palliative care is concerned. So there we go. Let me share the screen. Yeah. Okay. There it is, Zinhle. I think you can see it now.
Yes, I can, Mr. Master.
Yes,
Can you
okay.
hear me now?
Yeah, a little bit
Am I
now.
audible enough?
Yes, yes, yes. I don't know. Can we hear Zinhle colleagues? Yes. Can we hear Zinhle team? What?
Yes, we
Okay.
can.
Thank you. Go ahead, Zinhle. We can hear you well.
Good afternoon, everyone. My name is Mr. Vane. I'm working as a staff nurse at the palliative care unit at RFM Hospital. I'll be sharing with you a case today. We have a case of a 59-year-old May, a new case actually who is widowed, was the doctor diagnosed her with query advanced cervical cancer with some screening that they did. So she was referred to our department for management, palliative care, to provide palliative care services. So when we first saw the patient was stable. Personality stage was equal 1. And the problem of concern of the client was that the client was concerned about some lower abdominal pain that seems to be worsening by the day, but have not yet been started on any pain medication. And she did a biopsy in March this year, but the results were not yet out. So her chief complaint was low abdominal pain and some foul-smelling TB discharge. The assessment of pain was that the pain location was on the lower abdomen. She's experiencing some cut pain about 2 months now, and on the assessment, it was about 6. The pain score was about 6/10, and she said the pain was constant, background pain. For now, the pain doesn't much affect her functionality. She does do everything by herself for now. And since she has not started on any pain medication yet, so the pain meds on pain. So everyone, let me just go to the vital signs. The BP was 154, was a little bit higher, 155/122. Pulse was 116, temperature 35.6. The respiration rate was 13, O2 saturation was 98. Other symptoms that she had constipation. She said she had minor constipation, no dyspnea. Anxiety was mild, not depression yet, but she did have some mild fatigue. She also complained about nausea. A significant medical or physical history. The client was seen at RSM Gyne OPD in February 2025, complaining of low abdominal pain and a foul-smelling TB discharge. And a pap smear was done, and the results recommended that they do biopsy. Then biopsy was done in March, currently waiting for results. Then in May 26, 2025, client was referred to palliative care department for pain management and other palliative care services while awaiting biopsy results. Client is currently RVD on PLD. Past medication used by clients. Client is, when I saw the client, he was only taking PLD, OD. And the special investigations that were done was the pap smear that the findings of the pap smear was suspicion of cancer. Then she was done biopsy and awaiting results at that moment. Social history. My client is currently unemployed, being supported by her 5 children financially. She is active and stable for now. She thought that she is able to meet her daily needs by herself, even goes to the nearest forest to collect firewood and do all the house chores by herself. She is currently living with a granddaughter who is 8 years old, doing grade 2 in the nearest school, and they are living in a one-room. She lives an honest life. Her daughters are very supportive at the moment, and when the time comes where the client will be able to take care of herself because of the illness, they have resolved to take care of her. Then she also mentioned that she was so lucky to have a very supportive neighbors who frequently check up on her. Two of her daughters came with her in the hospital, and they stated that the doctors have already explained in detail the diagnosis of their mother to them, and even suggested that they get screened as well. Spiritual history. Client is a Christian who strongly believes in God as the source of everything. She is currently attending a local Jericho church. She stated that they are very supportive. She finds strength and hope in prayer. She also mentioned that she has accepted her diagnosis and is at peace with it. She believes that the doctors will do everything in their power to help her, and God will give them solutions. But if that does not happen, she is at peace with any outcome. And advanced care planning was not done yet. We probably with the next visit will discuss it with the client. Further plan of care to improve the quality of life of clients and family. Clients was registered under palliative care. Doctor reviewed the client and he prescribed diclofenac 50 milligrams COCID for 1 month, paracetamol 1 gram COCID for 1 month. With the elevated blood pressure, to get the client to 10 years clinic for a follow-up. Client health education consultation was done, and means were done to follow up with the results in Babane Government Hospital. We called the cancer focal testing there to follow up on the results, and we called the laboratory on our behalf, and the results. He found the results, so he even linked the client to Moneni. And when I called the client today, she said that Moneni has already called the client to see a doctor next week Tuesday for further management. So I can say that's all that we have at our end. I will open up for questions and maybe some additions from our colleagues to help us and how to help this client of ours. Thank you.
Thank you. Thank you. That was Zinhle's presentation on this case. Maybe to summarize the case, I will just say that Zihle presented a case on a woman with a 59 years old, who is a widow and has been recently diagnosed with cervical cancer advanced stage, who is functional status is ECOG 1, meaning he can walk around with the assistance of some medication to relieve the symptoms. And the major complaints that this client had was the lower abdominal pain that was moderate to severe, rated at 6, which was constant on the patient. And then this patient has been taken through the process of diagnosis and is able to be diagnosed with cancer and has been linked with Moneni. The major issue that this team had was that this patient had this pain and then was still waiting for the results. So they've tried to put a management in it, and this patient is also an HIV known patient. So he's on treatment, if not mistaken. I've seen something. Yes, she is one on treatment. So I would like to open for questions and recommendations. The RFM team is requesting for possible support, how best they can assist such a patient who have been just recently diagnosed. One thing we've noted from this patient is that he has a good family support. Even the children accompanied her to the hospital. Yeah, that's what I can say. Maybe if I can give opportunity to the team, anyone who may wants to add and or ask the RFM team any question, or who can want to add on how best they can manage this case, they are just requesting the team to share on how best they can support this team. Anyone who may like to ask or add as far as what they can do with this case. Anyone who can like to share something on this case? Maybe today I'm not having a very good clear picture. Yes, Mr. Lamini.
Yes, thank you, Mahlangu and the team, and thank you, Zinhle, for the case. I'm just happy. I'm just happy that the client is having the support from home. One thing that came to my mind is when it comes to communication, I'm wondering if I'm just wondering if they gave the patient their contacts so that in case of some side effects, the patient can call from home even before coming to the hospital. That's the only point I'm thinking about. Thank you.
Thank you. Yes, Mr. Lamini is asking Zinhle, how is your communication lines with the patient in case she needs some clarities at home? Have you been able to how do you handle those issues with your clients maybe?
No, thank you so much, Mr. Jamin, for that question. Fortunately, we made some links with my colleagues. We both a phone for our clients, and we give them that number to call us anytime they have a question or they want to come to the hospital.
Okay.
for advice.
Yeah. Thank you. Thank you. Anyone else who may want to ask or add something? Okay, mine will be to say thank you so much to share such a case. I've noted that the patient was enrolled on non-opioids or the just analgesic step 1 drugs, which was diclofenac and paracetamol for the management of that moderate severe pain. So mine will be, how is the patient, has the pain responded positively to those medications provided? That will be mine on the pain management, because looking at the patient has gone through moderate to severe pain for 6 months. So I don't know whether if it has managed to relieve the pain. I don't know. I would just like to know if that one has worked for the patient on your review, if you have managed to do some follow-up on the impact of the medication provided as far as controlling the pain. Then is there any plan ahead in case that pain is not responding to the first line pain medications? And then another issue is that I'm not sure in your referral to Moneni, was the purpose of referral explained to the patient? Because I think the results came back as advanced stage. If then that was the case, was the goal of referral to Moneni made clear for them? If you ask her, if they said they've called Moneni, did they explain what is going to happen at Moneni? So like the curative therapies, where they discuss with the patient, or he was referred to Moneni for further discussions, so he will find the most of the business and purpose of the treatment at Moneni. I'm asking this because some of the patients have myths concerning the treatment, and sometimes doctors don't explain the purpose of the chemo, and then find that patients are on chemo, but it's for palliation, and then they don't understand why are they put on chemo. I think that one will be my concern. One is the effects of the drugs. Are they effective to control the pain as yet? And then the issue of the goals of care discussion in terms of on the referral of or in terms of the chemo decision or further treatment. What was the treatment focusing on, if it was discussed with the patient? And then, yeah, maybe that one. The other issue of the family members' experience, is there any plan to engage the families on an education and the counseling as far as living with a cancer patient who's undergoing chemo? I don't know, or it's what the Manzini government, you requested them to continue with. I'm not sure, but those are the things maybe I would like to know.
Thank you, Mr. Masang. With the concern of the pain medication, today when I conducted the client, he mentioned that the pain medication is not really responding well. So what we discussed is that maybe he goes to Moneni first to see the doctors there, for them to further explain what will be their plan for her care. And then she will come this side for the pain management. But unfortunately, our hospital, and I think all over the country, we are in short of opioids. So I don't know what we can do then.
Okay. Thank you. So I don't know, did you say that the patient said the medication is not effective?
Yes, to
Oh,
say
okay.
that it's not.
Okay. Yeah. I wanted to say, I was suspecting that could be the case, especially with cancer. So I wanted to suggest that maybe you add the weak opioids, but if the RFM doesn't have the weak opioids, you can refer to hospice. Last time I checked, we had tramadol with us. So even though we know tramadol has some limitations with the elderly on the issues of seizure threshold reduction, so it lowers it down, we know. But for when morphine is not available, that's the only drug that it's on a little bit pure form that we can harness on. So we can work around on that one and see, banking on that, she will have the enzyme to metabolize it, so we can get the opioid effect out of it. So I think if you don't have, please call them. They can come to our office. I don't know how far they are. They can come, and they can even come to link the patient with hospice, so they can also be visited at home for further psychosocial support. Are your social workers gonna meet the family at some point to discuss on how they can support the patient?
Okay, thank you, Mr. Matang. On the issue of linking the patient with you guys, we did have the discussion with the relatives to go to your office. So I think I'm gonna call them again today to emphasize on that one.
Yeah.
So yes, I was planning on their next visit because this was their first visit on the
Okay.
26th.
Okay.
But we will also ask our social workers to see them. Because
Okay.
yes, they do need that company.
Yeah. Yeah.
Thank you.
Thank you. Yeah, that was from my side. You can link them with us. They will get the trust, because really, even if they are going through the pain, they will have a very big challenges when the pain is not controlled. And cancer has a tendency to have the pain excruciating and going up and again and again. So thank you so much. At least now we can bank on the support of the family and then help them access the service via our OPD. If they can also allow them to bring the patient, it's okay. But if they can't afford that one, they can leave at home and come and see. But we can appreciate if they can come with her, so the nurses can assess her, the OPD, and initiate her on the treatment. And then the follow-ups, they will discuss with our nurses to see how best they can be supported, while they also do the visit to see you guys at the RFM hospital and the OPD doctor, so they can get a little bit a more detailed care while they also go to Monen. But we are hoping Monen will do the job as far as maybe initiating them on opioids, especially with the weak ones. But if they have the lower doses of morphine, they will do, if that need, they will be. So we are hoping on that one. Anyone am I leaving behind as far as this client? I'm looking forward to say that maybe when she comes back, because we are missing the the Moneni team here. If then the patient comes back, please continue to review the issue of the the smelly discharge, so we can put her on Fletchy so we can deal with that smell again. Because that smell will repel the children in the house. I heard that you say they are staying in one room. So smelling has this, if that it stick to the clothes. So we don't want the children to walk in public and be labeled as the siblings or children of a woman with a foul discharge. So we want to eliminate that one. So please, whenever she comes back for review, please do check if the smelling is still a problem. Sometimes the chemo will help lower those discharges, but you can continue with the course and find out if she is doing well. But if it's not, yeah, I will suggest that we can put her on some few antibiotics to deal with the smell and then see it from there, because one of the issues now is that this the smelly thing that she's going through. But we hope the palliative care chemo will do something better, and the Moneni team will try to be as comprehensive as possible. Yeah, I don't know if I'm leaving something, but one thing I've learned from this case is the support from the community and the siblings. That was very good. And your efforts to link the patient, that was great. I've learned it from this case. Is there anyone I'm leaving behind before I go to our presentation? Is there anyone I'm leaving behind? If I'm leaving someone behind, all right. So I would like us to go straight to the advanced directives with these patients, because this case, will refer to it now and again in our presentation. And some of the concepts I will also use as an example. So can I share the slide so we can see the presentation? Yebo, there we go. So Yebo, what is happening? Yeah. Here's our presentation. So today we will be doing this advanced care planning. Maybe to just emphasize that I was happy in few days back. I saw in the news that Eswatini is in a journey to establish the tissue donation bill. I remember this bill was once tabled, so now it is under demand by the medical school. So I'm hoping this bill will come through. I haven't seen it yet, but I'm hoping once it comes, it will have this advanced care planning in it, because people will donate their organs for medical school. So they will have to have this in advance. So they will have advanced directives with them. So I'm hoping we are heading to that direction. And I'm hoping they will open it not to limit it only for organ donation, but they will open it for more scope in terms of it reaching to palliative care decision making. But one of the things that help us to deal with ethical issues is to have ACPs. So ethical dilemmas are more severe at end of life, and having the ACPs or advanced care plans with our patients can help us eliminate those dilemmas or reduce them. So we are going to define what an ACP and then outline some ethical principle guiding principles, and then we will explain the outputs and benefits of ACP conversations, and then we'll discuss universal principles for person-centered ACPs, and then we'll explore practical approaches to implementing ACPs in clinical practice. So we'll be just looking around this, and the presentation will be shared in our iECO platform. So if ever maybe you missed a certain slide, don't worry. The presentation will be available immediately after the session will be uploaded to our iECO platform. So what is an advanced care plan? So an APC is a person-centered process. So what we mean when we say it's person-centered process, it means that these are voluntary discussions about patients' care preferences while they are mentally capable. So, for example, with this case Zinhle's presented today, we need to understand with them that you are in stage 4. And currently, when the doctors from Monene, I will advise RFM team to call them and discover the type of treatment that is going to be provided and the goal of it. If it's then going to be palliative chemo, that means they are not reversing the problem, but they're just alleviating the symptoms without curative intentions. So then that means we need to engage on these voluntary discussions with the patients on care preferences, and while the patient is still mentally capable, because then now we know the disease trajectory. If you remember our first session in this, we talk about the disease trajectories. So while we are aware of the cancer disease trajectories, so we will need to be proactive and then engage on advanced care planning. So we need to prepare our patient for it. So we let them know we will discuss these preferences for them. So, for example, I might say, I would like us, when we meet next time, I would like us to discuss on your care preferences that you on your care preferences going forward. So this will help you. So when we're talking about ACPs, we are talking about that. These are voluntary discussions. So that what does it mean to say voluntary? It means that you always ask the patient and get permission to discuss. And remember, ACPs are very sensitive and you need to be culturally sensitive when you are conducting them. For that reason, they are voluntary discussions. They are not mandatory. So you need to propose them to the patient while they are still mentally capable. All right. And this one involves multiple conversations. So it developed over time with respect for emotions and wishes. So it's not a once-off thing. It takes time and patients changes over time. So you need to develop these conversations and talk about them. Put them in your schedules. Be intentional about them. When you are scheduling your patient visit or reviews, engage them on these issues and tackling elements each at a time. Remember, in palliative care communications, we don't bombard the patient with a lot of information, but we break it down into smaller chunks. So we need to engage them so that the family members can know what are the patient's wishes and how we can support them. And we need to be mindful of the patient's emotions. Sometimes we will stop because the patient is not emotionally stable today. So discussing such difficult conversations will aggravate the situation. So at that time, I will suggest whenever you get the opportunity to meet this patient, understand that ACPs, one, they are patient-centered process, and it involves multiple conversations. So it developed over time. So we escalate at a time, we take a little bit step at a time. Another aspect of these advances is that it's about empowerment. So why are we discussing ACPs in palliative care? We want to give our patients the power to make informed decisions and take control of their lives. What are we encouraging with ACPs? They are promoting the ethical principle of autonomy, beneficence, and justice. So we want to promote those ethics. So it increases involvement and reflection on what matters most. Remember, when we are talking about ethics, there are two rules that are there. One rule is the golden rule that was used in palliative care for a long time, that you do something that you prefer, it's ideal and matters for the patient. You judge on what the patients need. But now we have moved a bit closer now to platinum rule that requires you to do what the patient wishes and what matters most to the patient, not to you as a clinician. So this is very important to understand that when we are talking about ACPs, we are talking about patient-centered process that develops over multiple conversations and its intention is to empower the patient and involve them in what matters most. If chemotherapy doesn't matter most, only comfort matters most, then let's focus on comfort other than doing everything. Okay. So then we also have the legal presumptions that are there in advanced care planning. There are a lot of legal implications that comes with advanced care planning. So in Eswatini, I asked one of my fellow law friends, and then I asked him about if the country has something on mental capacity. So I was asking because I was thinking of that whenever my patient needs to make an advanced directive or an advanced care plan, they need to be mentally capable. So I was asking, what does the law of Eswatini says about that one? The one thing he gave me was that in Eswatini, we don't have what we Mental Capacity Act. We have what we call the Roman Dutch law, the common law. So under the common law, every person is presumed capable of making decisions unless proven otherwise. So what does that mean? That all the patients, they are capable of making decisions unless proven otherwise. For example, this client we are talking about today is an elderly approaching his 60s. And there is a tendency of family members to quickly jump in and make decisions for the patient. So unless it's proven otherwise, this patient is presumed to be capable to make decisions. So they must be told that they need to respect and honor and follow these decisions made by this patient. So in the country, we don't have the Mental Capacity Act, but we are governed by this. So whenever you are making decisions in palliative care, especially in making advanced care planning, remember this law of Eswatini, the common law. So this one is what we are governed with in Eswatini. In other countries, they have these mental capacity requirements that it requires the patient to have the capacity to make the meaningful discussions. So you need to, for that reason, all of us nurses, and I believe even doctors, we go through, we have a course on mental health because we need to understand and evaluate, be in a position to do MSE. So we can justify and say, oh, my patient has the capacity to make the decisions. And if we have some questions to ask her, then we have to get one of the IDT member, a mental health specialist or psychiatrist to do the evaluation for us to say, can you confirm for me that this patient has the mental capacity to make decisions? Because for you to say this is an ACP meant by the patient, your patient must have the capacity. And in Eswatini, we are saying that unless proven otherwise, and then otherwise it shall be confirmed here to say that I doubt that my patient has the capacity because of ABCD, but can I get a psychiatric review? And then the mental health will do their evaluation, and then they will tell you this one can make the decision, and then you go ahead. So that for that reason, in a palliative care area, we have an IDT team that we are working together so we can help one another. So if ever the business of the day or the purpose of your meeting and contact with the patient will be around ACP discussions, it is advisable to then contact a psychiatrist to help you evaluate, then you go ahead. If you are not sure that your patient is indeed having the mental capacity. All right. Another thing that we need to understand, the legal presumptions on this ACP is that it involves the carers and the family. So it's very important to include these people if capacity, mental capacity of this patient is limited. So you need to engage the families. Though this has problems if these family members will make decisions for the patient when they didn't understand much on his or her preferences of life. For that reason, if we push palliative care to public health, We push advanced care planning to public health too, because we want people like me and you to always encourage them to discuss medical care preferences, so that should it happen, then they are out of capacity to make decisions. And then now, as clinicians, we are relying on their family members. Their family members will have something to rely on to help make the decision on behalf of the patient, to become their proxy. So it's very important you understand these three, because if then you are going to make your own decisions, you will be taken to court and you'll be arrested. But then if you are going to push a patient who is out of mental capacity to make decisions, you will be taken to court. And if then you exclude the family from that process, you will also be taken to court by the families. So it's very important to ensure the families are here. Even if the patient will make the decision together with you, who has the capacity, ask them who else would they want to know about their preferences, and preferably family members, and then they will invite them. Then you will involve them into the discussion to say, I would like us to discuss on what your relative or what our client has preferred, so we can discuss and see how we are going to support them. I'm just saying too much on this because this is one of the things we need to understand. Otherwise, we need to update our documents so they can favor the discussion of advanced care planning in our care. So then what are normally the outputs of these discussions? One, they are shared care decisions. We are not gonna be able to meet and satisfy the needs of our client without understanding what these patients prefer or what these patients matters most to them. So with these advanced care decisions, they will help us when situations now are bad and there's an emergency sometimes, or tough decisions need to be made. And for us to be in the good side, we will have to have the ACPs. They will help us share the care decisions. So they make it clear mutual understanding between individual families, providers of future treatments, and goals. This issue to say so and so hospital kills people, so and so hospital doesn't help, will vanish, because we will have one and the same goals. For example, with this client who's taken to chemo with an advanced care diagnosis, we need to understand the ACP so that he can decide and say, should I be here? Don't take me to hospital. And in that way, we will have shared care decisions because of these advanced care decisions. So you don't wait until it is bad. Talk about it when it's still early and allow your patients to talk. Documented preferences. This is a very, very important thing. In the patient's file, there are patient wishes. We document their preferences. They matter the most. Patient today said she doesn't want to be taken for ABCD. Patient says she doesn't want to do this. Patient said she preferred to die at home. Patient said she preferred not to take antibiotics anymore. Documentation. These preferences must be documented. And then sometimes they can go further to be advanced care directives. Once an advanced care directive, it requires a legal perspective or a legal expert, because then now they might be legally binding. So we then need to go straight to, we then need to engage the lawyers. For that reason, legal advisors in the healthcare systems, that they are part of the team. I've heard that in Eswatini, they are looking around to have these free ex-legal experts to help people. So we need them in palliative care because they help document and make these preferences legally binding. Okay? When a patient comes to hospital with his advanced care directive document, and then you will know what to do and what not to do. Another output that we have is the emotional support plans. If we know what are the preferences of the patient ahead of time, we will then develop plans for supportive. and then help those people to handle with those challenges. So conversation address our fears and process emotions and identify support for person emotional needs. So these are the outcomes. The reason we're saying let's discuss this is because of these outcomes. They are very beneficial to the patient and they also help us as clinicians. All right. And then there are universal principles for ACPs, patient-centeredness. And remember, it must be always patient-centered. If it's not patient-centered, then it's not palliative care. All right? It must be patient-centered. Always ensure it is patient-centered. So whatever we are doing is not about family, it's not about anyone, it's about the patient. All right. So one, it must be voluntary and flexible. Okay. So the person control it. So that's what we need to understand. It is voluntary and it's flexible. So they control when, with whom the ACPs happens. That they are the ones in charge. Number two, it's an ongoing process. ACP over time, I've already said it, respecting the pace and needs. A patient will say, not today, and then you postpone to next time. Never give up, but keep on knocking by the door because it's a process. It depends on how the patient is doing today. And then it requires supportive resources. Information and professionals are available for informed choices. Please, whenever you are thinking of advanced care directives, be available and have enough information because this is a decision for life and death. So the patient needs to understand what to do and how to do it. So you need to provide in-depth information and not hold anything. So that's what I will be requesting from you to do when we are thinking of discussing advanced care directives. Put the information, put your resources in order. And if there are things you are not sure of, yet you have scheduled an ACP discussion, inquire, go around and do some consultation and ask. And then come to the discussion table with more informed, because you are here to help the patient. If you feel like you are not going to be able to define any concerns very well, get permission from the patient to bring those aspects with you to the discussion table. Let's have the conversations. All right. So future care conversation focus on what matters. So how do you go this? First of all, to know what matters most to the patient, you need to explore priorities of the patient. And we are not going to know the priorities without asking the patient what matters most to them at this point in time. So start with quality of life means to the patient. So you ask them, what does quality of life means to you? What brings value to you? What is of value to you at this point now? And then this one helps you to explore the priorities. Some patients will state things that has to do with assets. Some will do things that have to do with relationships. Some will do things with medical decisions. So then this is when you kickstart the conversation. So you explore the priorities. All right. Two, it requires clear communication. You need to be honest, understandable information, considering the limits of treatment. We cannot push person to highest limit, but we need to understand and be honest in our conversation. Be clear if this is for palliative chemo. Tell your client this treatment is not gonna cure it, but it's for palliation. So why? Why are you telling the patient this one is not gonna cure, but it's gonna palliate, and these are the side effects, these are the benefits? So the patient can make an informed decision. So you need to be clear. You need to be clear to them and be honest about what you are talking about, knowing the limits that sometimes we will need to stop. And then it's use of trained interpreters if there is a need, especially for those who have who have hearing impairment or speech problems. we need to get people to help us. As clinicians, this is an area we are missing, and that our care has limits when it comes to helping these clients who have cognitive limitations. So we need to get people who are professionally trained to help us interpret, because you cannot exclude a patient just because he's deaf. Then you are going to exclude him on these discussions. He has the right to make the decision, because after all, he is the one or she's the one who's going to be impacted by what matters most. And these ACPs needs to be centered around that patient. Okay. And then shared decision making and ACPs involve respect for preferences. We need to respect the decisions that the patients have made. Even if it's against your values, it's against your ethics, it's against the family values and ethics. If it's for the patient, we need to respect that, and we need to educate the families that black on white, we need to respect the patient's preferences. So decisions reflect patient's values and clinicians' knowledge. So whatever the patient decides to make a decision on, it's based on what? It's based on the values of the patient and the information she or he was provided by the clinician. For that reason, you need to be honest and be knowledgeable about the topic you've been discussing with your patient. And then another thing, when we're talking about such decision making, we talk about the right to refuse treatment. Patients have the right to refuse treatment. Remember, every right has its obligation. So we need to teach them that patients with the capacity, mental capacity to make decisions, can decline treatment if they find it unwise. So we need to empower them to know when to stop, because sometimes patients will keep on coming to hospital even if they feel like it's not benefiting them. So they need to be on control of their health, and they need to make decisions on their own. So these ACPs help them to get the courage to tell us. For example, this woman we've been talking about today, if she feels like he's been doing the chemo but it's not working for her, and he has all the information and understanding of its purpose, any decision that patient will make, if she refuses to continue with the chemo, we are not there to force her to continue with the treatment, but we are here to support her in whatever decision she made. Remember, they are in charge of their healthcare. And then as clinicians, we provide recommendations. We don't make decisions for them. We can recommend things they can make decisions from. So we need to timely advise this patient and help them to make the decision. So whenever there are clinical changes, we provide the advice, and it must be timely. And we need to always provide the advice information, and then the patient makes the decisions. Okay? How do we implement ACPs? How can I go about implementing? One, ACPs are not static. They are not a once-off activity. They are progressive by nature. You do them now and again and again and again and again and again until the patient dies. And patients usually, they change. Last time you said, I want to die in hospital. Next time I want to die at home. Next time I want to die where? Next time I want treatment. Next time I don't. Then what does this mean? It means we need to reevaluate and update our files every time we have a contact with these patients. You don't ask them once and rely on a 3-month statement by the patient every day. On admissions, our files need to be updated on implementation of ACPs. So if you are admitting a patient, because the outcome of an admissions is 2 or 3, you can be admitted better, you can admitted the same as you came in, or you can be admitted worse than before, discharged, death, or worse. So then you can come into hospital walking and exit not, because the outcomes are not within our control. We are control all the outputs of whatever we've been doing every day. So we need these ACPs with these patients so that We update it every day. Some patients, they don't want a blood. Some patients, they don't want to be admitted. Some patients, they don't want to die in hospital. Some patients, they have their preferences. So we need to update their plans every day and over time, and because they evolve, they change and change and change. For that reason, we need to update them. So when we are implementing them, when we are meeting your patient, check on the preferences. Has there been any change in the preferences? Version control. Ensure the most current plan is clear with previous versions readable, readily accessible. You don't discard the old decisions that patient shared with you. You keep them. It becomes like a document of decisions that the patients have made over time. So as they are confronting situations, some will say, I want to be like this, and then they go through, they see some experience that they don't like, then they change. You keep the record so you can monitor what is happening with your patient, okay? And then it involves supportive culture. You know, we need, organizations should promote a respectful and collaborative culture for ACP process. You need to just promote respectful and collaborative. Be with them, support them, help them go through the process. They will change the preferences, they will change the ACPs, they will change now and again and again. Our duty is to support them if they change, get the understanding why are they changing, and then support them through. And the families will be hurt, but the patient will keep on, be on the drive seat. Okay. And then last but not least, I would like us to take home this, that ACPs improves patient care and family satisfaction. You know why the health system has a lot of dissatisfaction with our patients? It's because we are providing care not centered around their preferences. We are providing care centered around our affordabilities and preferences, not the patient. The patient is not on the driving seat. But ACPs improve satisfaction by giving the patients the driving seat. And then we come as a supportive system to support them. And that's why palliative care have a power or has influence in reduction of hospital cost directed to patients with palliative care needs. Why? Because some patients tend to prefer dying at home, not in hospital. How much does it cost to have a patient admitted for 2 hours or 1 day? It's a lot of money. But these patients will end up finding that they want to die at home. They don't want IVs. They don't want resuscitations. We are cutting all those costs. Why? Because we have banked on ACPs. Our patients are on a driving seat, and we know. And remember, even if they are the ones who are leading the care, but we know every right has its obligation. So we need to know that ethical principle, justice, sometimes the patient cannot say, I want to be killed. It's unethical. We cannot do that. All right? Sometimes you will find that the patient wants to be killed because there is severe pain. So we need just to manage the pain, and then the patient will change the wishes to something valuable and something of greater value to them. And then conversations should be voluntary. So you need to ensure the conversations are voluntary and ensure that they are personalized and they are ongoing. They are not just static, and they need to be set around the patient. All right? Respect legal rights and promote shared decision making. Always when we are doing your discussion, be aware that they have the legal rights and promote shared decision making. Make the families be involved. Then they add ACP. So one of the questions that we have in hospice documents is that when the patient is making the advanced care decision, you ask them who is also aware of this, or who else would you like to be in this? Because we want these decisions to be shared so that this document can be used effectively even when situations are bad, and especially it helps when there are emergencies or when there is a critical decision that needs to be made as far as the patient's care. All right, but you can access this information from the National Health System of England or Compassion in Dying website. So you can get much of this information on the ACPs. They are well articulated there. Otherwise, thank you so much. This is what I can share as far as ACPs are. So then I cannot go deeper into the advanced directives and stuff, but these are the basic things I think we may need to harness as clinicians as we think of developing ACPs and engaging in advanced care planning discussions with our family, our patients. So the base thing is that you don't need to wait for the lawyers to be involved. ACPs, once they go for advanced care directives, they will require you to have a lawyer involved. But if it's within the wishes and preferences, please document in the patient's files and help those files and document the needs of your patient. Otherwise, you will continually provide care based on the golden rule other than the platinum rule, which give the patients the driving seat on preferences. There is nothing so shameful and difficult like doing things for the patients other than supporting them do their things or providing care to the patients that is outside their preferences and without a shared goal. So ACPs will help us achieve that one very well, because even when difficulties and we have conflicts with the families and when ethical dilemmas are kicking in, should we resuscitate? Should we intubate? Should we put IV fluid? Should we feed by tube? So those decisions will be held by what? By having the ACPs. So this is one of the aspects that is lacking in Africa and Eswatini in the West. So we need to embrace it so that our patients can be empowered and our clinicians can understand that it's not about us actually, it's about their patients. And the families could understand why is it important that they respect the patient's preferences. And the family members and the patient needs to be helped develop this. So it's very important to be strategic when you are setting your contact with the patient. Let them know ahead that next visit, you would like us to discuss on ACPs. I would like us to have conversations on ACPs. And remember, it's an ongoing process. You can focus on one aspect today, and next time you look at the living will, next time you are looking at organ donation, next time you are looking at preferences on medicines, next time you are looking at preferences on places of care, next time you are looking at all these things that are involved in ACPs. You can discuss them. Remember, the patient can change it again and again and again. So it's a continuous discussion. So having good communication skills as clinician is a must whenever we are in palliative care. And remember, 90% or more than 80% of our skills that help patients improve, it is centered around communication and making palliative care patient or person-centered, other than clinician or health facility centered. Thank you. That's what I can share today on ACPs. And remember, we are looking at them in the context of end of life. And so don't wait until your patient begins to gasp or begins to have frequent hospital visit to show that they are now going to die. Start early. Actually, if you have a facility, I'm promoting and we are advocating that ACPs must be moved up to primary health care. Move them to those who are healthy. Do you have an advanced care plan? What can happen if you can be knocked by a car right now and you're unable to talk? What are your medical care preferences? Those hard conversations, let's put them to our people. In facilities, let's do some surveys. Let's see what people are preferring, and then it will help us. Or let's structure our document so that in every department or ward or space where we have contact with patients, they could be asked concerning their ACPs. And then we will evaluate the impact of following ACPs and see how it can improve public health and help people to make informed decisions. Thank you so much, colleagues. Anyone with a question or suggestion or addition, I would like that today. I have 15 minutes, actually I have 14 minutes left for us to discuss. What is your experience? Do you have an ACP in place? Where would you like your body to be buried? You know, what casket would you like to have? What type of funeral would you like? What will happen to your money in bank when you are dead? Do you have a plan in place? What will happen if you have a cardiac arrest today? What would you like to happen to you? These are the questions we need to ask ourselves. If that is difficult for you to ask, then it means it's hard for the patient. These are critical conversations that are tempting our culture, limits, and beliefs. Okay? Yep. So, yebo. Anyone who wants to contribute or say something? We're looking at advanced care planners. So it's a bigger thing. Yes, Mr. Dlamini, I can see you on mute.
Oh. Yeah, you were very quick to to see me. Thank you so much. Thank you so much, Mahlang. That was a mouthful, and you are right. You know it affects our culture in a way. We have to learn. We have to learn as we go along. I just have some comments as I was listening to your presentation. I'm remembering what the people living with disability usually say in their organizations. They have a motto to say, nothing for us without us. So I think we can learn from such words. They like to encourage one another by saying nothing for us without us, so that people cannot make decisions for them without involving them. And also these issues of inclusivity and equity and the preferences. This reminds me of writing a will. They say that when you're writing this will, it is not static, like you were saying. It is something that can change from day to day. Otherwise, what is considered is the last will that you have written just before you pass on. So it's something that is ongoing. So as we are learning these principles, I think we are all going to benefit. And indeed, they are hard questions. These are hard questions because we don't know what tomorrow will be like. So if, like we are saying, if it is hard for us healthcare workers, how about the patients? So it's hard, but together I think we can reach somewhere. Yes, it is good to be patient-centered so that the care that we provide, they are involved, and in this planning they are also involved, so that in the long run they will not be blaming the healthcare workers. Thank you so much. Thank you,
Thank
Mahlang.
you. Thank you.
Yeah.
Thank you, Mr. Lamin. Actually, if we have ACPs, there will be less legal cost on us. There will be less legal cost on us. We will always be on the right way, but it's a combination. We have them, then at hospice we have those situations, but then the families are making decisions for them. Think of it. Currently, we have a high incidence of CVAs, like stroke. Stroke just knock you today, you are unable to speak anymore. And there's nothing painful to see people taking you to where you didn't want. But because there was no time when you share, you hint them on what you would like and prefer. Should you and you are unable to make a decision on your own, you are mentally incapacitated. I don't know if that's how we say. I'm not able to make decision on my life. So sometimes playing around, I usually say, when it's a Good Friday for those who are Christians, when it's a Good Friday when Jesus died for us, let's discuss about death on that day. So I tell them, should I die like Jesus too? This is what I would like. Should I be unable to make decisions? This is what I would prefer you to do for me. So those are difficult conversations, but when we discuss them, but my experience with these patients sometimes they are difficult when we are discussing with them because some push them to hopelessness. But if you have done thorough based on understanding their emotions on that day, because if your patient is emotionally unstable, please don't dare push them to advanced care directives. You will push them to suicide because they will just say, even the nurse could see that I'm dying. and now he's asking me about advanced care planning, it means that I'm going to die. So you need to understand how is my emotional. So the first thing, how are you doing today? Is there anything you're struggling with today? If it says nothing, I would like us to have a sensitive conversation today. Do you know this spike formula thing we use to break bad news? Yeah. I would like to, so you prepare the patient to bed news and then you kick in. I would like us to talk about the moment when you are unable to make decisions for yourself. Do you have a plan in place? Some patients will initiate the issues of death. And you know what? I'm tired, Matlang. I want to die now. This is a moment to discuss about it. Have you planned how your death will look like? You know? And then they will begin to discuss. Then you push them to those limits. What should happen should this body lose blood? Would you like us to put the blood? Should we be able to breathe? What about intubation? Should we be able to eat? What about anti-tube feeding? Should we be able to, we are dehydrated? What about fluid? So we are discussing, what is your take on this? What is your take? What about the place of death? Where would you like to die? So their families have helped to when the patient wants to discuss those issues, but the families are reluctant. So when I come, then the patient bring back about the story, and then I'm facilitating the conversation. Then you discover that the families now they are understanding the need for the patient to discuss those issues rather than turning them down, because in our culture, especially Swatini, death is a taboo, you know. Yet in palliative care, death is a normal process. So we need to demystify this concept, but culturally sensitive. You need to move with them at their pace and emotional understanding. In that way, it requires time. But don't put a lump sum of information at the same time. Put it in small chunks. Take one aspect in a day. Sometimes be sensitive. That's why in palliative care, communication skills are key, especially listening. Listen very well when patients are speaking so you can detect even messages behind the message they are sending to you. Because sometimes they will say things. If you are not listening very well, you will lose the core driving force of certain conversations with you. And it's very critical to have a good rapport with them. And don't expect patients to trust you with deep information on the first day. But the more you are open to them, you are showing them that you are here for them, they begin to trust you and they will open up a bit and a bit. And then that's when you will begin to move and move. But we cannot ignore the structural part of it in our programs, that we need to have a structure. Know exactly when sensitive issues comes, how are we going to take it then? The issues of capacity. If I cannot mentally evaluate my patient, who can be responsible? Because these are serious issues to be discussed. And remember, if you have agreed with the patient on a certain preferences, ask permission for the patient to discuss with your team, and let that also be communicated with the family members. All the decision makers that will be impacted by that patient's decision need to be discussed. In that way, you will be in a position. But remember, they are not static. Every day they are changing. So we need to praise. Mr. Dlamini, thank you. Mr. Dlamini says thank you, Mahlam, and Mr. Dlamini, who is this? Oh, Zinhle is saying that was very informative presentation. Thank you, Mr. Dlamini and Mr. Mahlangu. This was really an eye-opener. You are right that it has to start with us so it can be simple to discuss with our clients. Yes, that one I'm a testimony. It's better when you are discussing those conversations. Start with your family so you can feel the resistance and then think about it when you're this patient. So, and it's never late. You can still start now, have those conversations, and then start with one patient, pull them through, and then we learn by doing. Thank you. Anyone else? Margaret Kamete?
Thank you so much, Tim. Thank you for the presentations. From the case to the presentation, it has been so informative, enlightening, and challenging. Mahlangu, when you were making a presentation, you talked about the issue of the act, where we were saying the patient has the right to either accept or refuse treatment. I just want to make a plea to us as health professionals, kakhulu bonesi. I think one of our key role is to advocate on behalf of the patient when the patient can no longer do it. I have received a number of concerns or complaints from patients, especially those under palliative care, that when they do not accept certain treatment at the bedland, then when they go back with other complaints, they are just told, when you refused this, so we cannot do anything for you. Passing this plea, balingani bethu, let the nurse still take that role of being an advocate for the patient. We cannot allow people to be turned back or to die in pain or to die with those symptoms control just because essentially they refused to take a chemo at one point in time. They are refusing because they are the ones feeling the side effects, as the presenter was saying. They are the ones who, after all, have been well informed that this is not going to cure you, but are only palliating these issues. So let us not turn people back just because they refused a certain treatment to one point in time. Can the Lord help us ukuthi siba-advocate-ele, sibakhulumele in a way that will make the other team members alo msebenzi wethu to take it upon themselves to say, let us do this for this patient, more so because we are aware that the end is ultimately the end is death. So why should we deprive this person the symptom control just because he or she refused one initiative that we provide? Thank you to all of you. That was just my plea and my concern.
Thank you, Marge. I can't explain much more than she has said. Yeah, I think all of you can reflect and say that those are instances. Patient can say today, I don't want chemo. Few down the line, he wants it. You don't deny him. Yeah, thank you. ICPs. Yes, anyone else who may want to share before I close? It can be your experience. It can be something you have seen that happens around ICPs. It's okay. Thank you. Yeah. All right. In the absence of any comments, let's go and start having the ACPs. They will help us. And then remember, once we have discussed with them, write it somewhere. Let it be documented and let it be known. In that way, we will provide the best care to our clients and make them feel happy and be satisfied of the care. Remember, we are here to improve quality of life, not change the direction, but quality of life, regardless of the direction of the prognosis, whether it's recovering, whether it's deteriorating. We are going that way. Sister Mbata is saying, thanks, Mahlangu, for the presentation. Some clients may have challenges regarding the fees of the will. Yeah, it was going to be better if the ministry can assist with this. Health workers also need to be informed regarding such issues to advise our patients. Yeah, I'm praying that Eswatini will graduate. Actually, this is a multi-stakeholder, it's a multidisciplinary, palliative care is multidisciplinary. It needs everybody. I think even the Ministry of Justice and Constitutional Affairs, yeah, something like that, can have something to give in terms of the law for these patients. But so far in our status quo, I doubt, I'm not a legal person that much, but I doubt the country is ready to give people the right on their rights when it comes to making decisions. It's like you eat the food that's already on the plate. Whether you like it or not, I'm not sure. I don't want to lie, but indeed we need, because some of us, law currently it's economically determined. If you don't have money, you are not going to have legal things. Yet wills, people have currently they out there. We have had a case at hospital whereby the patient wanted to decide in terms of her assets, the animals, and then because he cannot afford a lawyer for the will and those things, so it was challenging. but we managed to help them at least find ways to make that decision known to the families and be legally known, and then engage those people who can help just in case the patient is not there. Yeah, let's brighten the corners where we are. Thank you so much, winners. Thank you so much. Let's go out there and then let's share it. You can take the presentation and share with others. It's okay. You can also visit my YouTube channel and then you will be able to access the video. Thank you so much, colleagues. Let me make the announcement for our next meeting. So today we're looking at those ambiguities in terms of symptom control as ACP is concerned. We hinted on that. For that reason, in our next session, we will look at symptom management at end of life. We will be looking at those ambiguities. How do we deal with these symptoms when we are approaching the end of life? So we will be looking at those symptoms and then it will not be all, but we'll focus on those that have dilemmas and then see if we can apply the ethics and the ACP issue on them and see how best we can manage such symptoms at end of life. So our next session will be on the 2nd of July, 2025. So we'll meet 2nd of July, 2025. Immediately I'm done with this, the presentation will be uploaded to our iEco platform. You can come in and come to the session and then you will find the material, including the case. It was uploaded also to the platform. It's already there, but the presentation, I will upload it right now. Thank you so much, colleagues. Hope all of us have learned something from each other. Sister Mbata, thank you. Thank you. See you next time.
Bye.
Bye-bye, sister.